Assalamu alaikum everyone. Hope you are all safe and hope we can all resume our face-to-face lectures soon. My name is Abdallah El Kateb. I'm a professor of OBGYN, and today we're going to talk about an important topic, the uterine fibroids or the uterine leiomyometer. It's important because the fibroids, they're the commonest benign tumors of the female genital organs. They arise from a single muscle cell within the myometrium, and they are extremely common. They're almost detectable in around 20 to 25% of women in their childbearing period, and some studies have shown that up to 50% of uteri at autopsy have shown that they include some sort of fibroids. They grow very slowly in size over many years, and they are mostly asymptomatic. They have a very low malignant potential, and because they are asymptomatic, they can pass unnoticed. They also have a very slow progressive course. They are usually diagnosed if they are large sized, symptomatic, or in most of the cases, they are accidentally discovered. Risk factors for uterine fibroids, they include nulliparous and low parity women, a positive family history, like a mother or a sister who has been diagnosed with fibroids before. They are more common in obese women, and they are more common in dark races. They sometimes have associated conditions, like a follicular cyst of the ovary, endometriosis or adenomyosis, endometrial hyperplasia, and quite rarely endometrial carcinoma. The etiological factors include a hyperestrogenic state, and this is why we usually find the uterine leiomyometer in the childbearing period. It's actually only there in the childbearing period with no new tumors developing before puberty or after menopause. This is why they're commonly associated with endometrial hyperplasia, and this is why they can increase in size during pregnancy and during estrogen treatment, like in the case of combined oral contraceptive pills. And this is also why they undergo atrophy after menopause. There are certain growth factors that have been implicated as an etiological factor with an increased production of epidermal growth factor and a decreased production of growth inhibiting factors. There are some genetic factors as well, shown by the cytogenetic abnormalities that are present in around 40% of cases of myometer, and by the fact that the myometa are liable to recur after removal. The pathology will have to include a site. So we have corporeal myomas, which are around 96% of the cases, cervical myomas, less than around 4%, and broad ligamentary myomas, which are around 1%. The types of those myomas will include interstitial myomata, like the ones that are shown here, where they are lying within the myometrium itself, a subserous myoma, where it is only in the myometrium, but it is encroaching on the serous membrane, or a submucous myoma, where it is encroaching on the endometrial cavity. The subserous myoma can become pedunculated, as in the case like we're showing here, or a submucous fibroid can become a polyp and becomes inside the uterine cavity. The size of the fibroid is quite variable. It can start as a seedling fibroid, which is less than 1 centimeter. However, it may reach a huge size, occupying the whole abdomen. The shape is usually rounded or spherical, and the number varies widely. It can be just one myoma, or they can be multiple. The consistence is usually firm in consistency unless it is degenerated or a complicated myoma. The cut section of the fibroid will show a paler appearance than the normal myometrium. It will have a whirly appearance. There is a pseudocapsule of compressed normal myometrium surrounding the fibroid, and blood vessels, they usually lie within this capsule. The microscopic appearance will show that smooth muscle fibers arranged in bundles. The fibers are elongated with spindle. There are certain pathologic changes that can happen in fibroids, and those include atrophy, hyaline degeneration, cystic degeneration, fatty degeneration, calcification, necrosis, infection, and a pathologic change that can happen peculiarly during pregnancy, which is the red degeneration. Now, atrophy. This is the commonest change that can occur during the time of the menopause, and it is usually due to a decreased blood supply, secondary to what? Secondary to a decreased estrogen. It occurs during puerperal period, that is following the rapid growth that can happen during pregnancy, and it can occur after a long-term treatment with GnRH agonists. Clinically, it is just silent and painless. Hyaline degeneration, that is the commonest change that can happen in the childbearing period. It usually happens in the center of the tumor. Why? Because of the diminished vascularity. As we said earlier, the blood vessels, they usually lie in the capsule. And microscopically, we will see a decreased whirly appearance, and the tumor tissue is replaced by homogeneous structureless material staining pink with eosine. Clinically, the tumors, they become softer in consistency, and they may be associated with mild to moderate dull aching pain. This hyaline degeneration can progress into a cystic degeneration when there is an absorption of the liquefied hyaline material. Microscopically, we will find cavity lined by remnants of the unabsorbed hyaline material. And clinically, the tumor becomes soft or even cystic. A fatty degeneration, meaning that there is a deposition of fat within the muscle cells, and this actually is a precursor for calcification, where there is a deposition of calcium phosphate and carbonate. It is either a peripheral calcification, producing an eggshell appearance, or a diffuse calcification, producing a wormstone appearance. It can be detected either by ultrasound or a plain X-ray, and it is a quite common occurrence during the time of menopause. Necrosis commonly occurs at the tip of a submucous fibroid polyp. Why? Because of the decreased blood supply. It also occurs following torsion of a pedunculated subserous myoma. Infection can happen at the necrosed tip of a submucous fibroid polyp projecting into the uterine cavity, or it can happen during the puerperal period or as a spread from a nearby infected organ as appendicitis. The red degeneration or the necrobiosis, it is the commonest change occurring during pregnancy. Why? Possibly due to the fibroid outgrowing its blood supply because of the rapid growth, or because of this increased growth, a kinking of the blood vessels occur, or due to the increased thrombosis that can happen normally during pregnancy. This increased thrombosis will cause ischemia, it will cause intravascular hemolysis, and the diffusion of blood pigments, hence the red color. Clinically, the myomas become enlarged, tender, with acute pelvic pain and a mild pyrexia. The management is usually conservative by rest and analgesics as nonsteroidal anti-inflammatory drugs. Hemorrhage, or it can be an incarceration or impaction of a subserous myoma in the pelvis during pregnancy. Here we have images showing a fibroid that is calcified, a fibroid where there is red degeneration, hence the red color, or a sloughing of the fibroid with necrosis in a submucous fibroid polyp. We can also see a cystic degeneration where there is absorption of the hyaline material in the fibroid. We can see an incarceration where the fibroid is impacted in the pelvis. This incarceration, if happening during pregnancy, it can cause a dystocia where there is absence of fetal descent due to the presence of the fibroid. Malignant change in a fibroid is quite rare, occurring in just 0.2 to 0.5% of myomas. Malignancy is suspected whenever there is rapid growth without evidence of degeneration, or if it first appears or increases in size during the time of menopause, or if we find postmenopausal bleeding, or if this fibroid rapidly recurs after surgical excision. Macroscopically, or a gross picture, will show a yellowish in color fibroid that is friable with areas of hemorrhage, and we will find capsular invasion leading to a difficult enucleation during a trial to remove it. Microscopically, we will have a 10 mitotic figures per 10 high power field, frequent cellular atypia, and coagulative necrosis. Fibroids can have an effect on the surrounding pelvic organs. The fibroid first will affect the uterus itself, leading to a uterine enlargement, whether that enlargement is a symmetrical or an asymmetrical one. It can cause a distortion of the endometrial cavity, like in cases of a submucous myoma or a submucous fibroid polyp. It can cause a displacement in a uterine position in cases of large myomas. It can cause an increased vascularity and venous congestion. It can have a pressure on a urinary bladder, leading to frequency of micturition, or an overstretching on the urethra by a large cervical myoma, leading to a retention of urine. It can cause compression on the ureters by a large cervical or broad ligamentary myomas, and this leads to a back pressure on the kidneys, leading to a hydroureter and a hydronephrosis. Now, the clinical picture of a fibroid. How will this woman present? Usually, it will be a woman in the childbearing age. However, they're more prevalent at ages ranging between 35 to 45 years. As we said earlier, they're more common in obese women. They're more common in nulliparous women and those with low parity. The fibroids are usually symptomless. They are usually asymptomatic. And they are usually accidentally discovered during a routine exam or by pelvic ultrasound. Symptomatizing fibroids usually happen if they are larger size fibroids, and they are usually symptomatizing fibroids. We will have menstrual symptoms. Menstrual symptoms. The most common menstrual symptom will be menorrhagia, and this will happen in cases of submucous myoma due to an increased surface area of the endometrium, due to a mechanical interference with the uterine contraction, as we said earlier, an associated endometrial hyperplasia, or due to the increased estrogen, we will be having a hormonal imbalance, or an increased myometrial vascularity. So the most common symptom in bleeding will be menorrhagia. However, sometimes we can have a metrorrhagia, like in cases of a submucous fibroid polyp with a sloughing of the tip, or sarcomatous changes in a fibroid, or associated condition as a disturbance in pregnancy or a coincidental uterine carcinoma. Fibroids, as we said earlier, are usually symptomless, so they are usually painless, unless complicated. Pain may be dull aching pain, like in cases of hyaline degeneration, infection of a submucous fibroid polyp, and sarcomatous changes. Acute abdominal pain can happen with red degeneration that happens during pregnancy, or it can happen with a torsion of a pedunculated subserous myoma. A colicky pelvic pain can happen in cases of extrusion of a submucous fibroid polyp through the cervix. We can have congestive or spasmodic dysmenorrhea, as in cases with submucous myomas and polyps, or we can have pain due to common associated conditions as endometriosis. Pressure symptoms can be on the urinary bladder, leading to a frequency of micturition and dysuria. It can be on the urethra by a large cervical myoma, leading to a retention of urine, or it can be on pelvic nerves, leading to a referred back and thigh pain. Infertility, it only happens in around 5 to 10% of the cases. And the mechanisms that may cause infertility include interference with implantation or a tubal obstruction caused by the site of the fibroid. Other symptoms will include pregnancy complications like a recurrent pregnancy loss, a preterm labor, dysfunctional labor, malpresentations, obstructed labor, or a postpartum hemorrhage. Other symptoms will include leukorrhea and a progressive abdominal enlargement. Differential diagnosis will include other causes of pelvic abdominal swellings, other causes of symmetrical enlargement of the uterus, a calcified shadow on plain X-ray like in the case of a calcified myoma, or a mass protruding from the cervix like in cases of a fibroid polyp. Special investigations will obviously include ultrasonography, whether that is an abdominal ultrasonography or a vaginal ultrasonography. It can include a CT scan and MRI, especially important in cases where we are trying to investigate virgins. In hysterosalpingography, we can diagnose a submucous myoma and a submucous fibroid polyp. Obviously, endoscopy is an important investigation where we can use a hysteroscopy or a laparoscopy. We can see images here of fibroids seen in ultrasound, fibroids or fibroids. Here we can have a fibroid that is pressing on the endometrium, so we know that this is a submucous fibroid. Here we can see an image of an eggshell appearance with calcifications all around the myoma. For the management of fibroids, we can have several approaches. We can start with a conservative approach where we just do regular follow-ups without treatment. We can include a medical treatment or a hormonal treatment for the associated symptoms. There are minimally invasive procedures that we can use to avoid a surgical approach, and there is obviously the definitive surgical treatment. The conservative approach will just include a periodic follow-up every 6 to 12 months for mostly asymptomatic cases, and during pregnancy, and during a cesarean section, where we usually prefer to avoid doing a myomectomy during the cesarean section unless it is at the site of a uterine incision. A medical treatment or a hormonal treatment will include modalities to control moderate bleeding and pain. This can include non-steroidal anti-inflammatory drugs, hemostatic drugs, venotonic drugs, or in the form of hormones like gestogens to counteract the increased estrogen, or GnRH agonists in a trial to decrease the estrogen, leading to a secondary amenorrhea with a reduction in the size and the vascularity of the myomas. Or can include an MRI-guided high-frequency ultrasound. Now we come to the definitive treatment, and that is the surgical management. The surgical management will include either a more conservative approach, which is the myomectomy, or a more radical approach, that is the hysterectomy. Indications for a surgical removal of a leiomyoma will include a large size fibroids, will include myomas causing severe uterine bleeding, or myomas that are causing complications, either to become pregnant or during the pregnancy itself. It will include any growth in size of a leiomyoma during menopause, or a submucous fibroid polyp protruding from the cervix. It will include cervical and broad ligamentary leiomyomas of intermediate size. The more conservative surgical management, which is the myomectomy, is usually preferred in patients that are young in age, that are desirous for further fertility, or just seeking a preservation of their menstrual cycles. This can be an abdominal myomectomy, a laparoscopic myomectomy, or a hysteroscopic myomectomy for a submucous fibroid polyp, or a single submucous fibroid that is less than 5 centimeters in size. The aim of the myomectomy is mainly the surgical enucleation of the myomata from the myometrium while trying to preserve the uterus. Why? Because we're trying to preserve the fertility, or because the woman just wants to keep her regular menstrual cycles. The advantages will include decreasing the symptoms. That might include bleeding, pain, just a mass, or the infertility. It will preserve future fertility potentials, and we're keeping the normal menstrual function. We were just stating the indications for a myomectomy. We will have some contraindications on why not to do a myomectomy, and this usually includes women that are after menopause or in the premenopausal period. It will include pregnancy or at cesarean section, unless it is at the cesarean section scar site, or if we have a pedunculated subserous myoma where we do not expect a lot of bleeding afterwards, or if we have a suspicion of a sarcomatous change. Obviously, if we suspect sarcomatous changes, we cannot just simply do a myomectomy, and we will prefer a more radical approach, which is the hysterectomy. Complications of myomectomy will include excessive blood loss at operation, a higher incidence of post-operative complications like fever, anemia, pain, and ileus. Obviously, we will face post-operative adhesions. We might be facing a persistent or a recurrent menorrhagia. Why? Because of missing a small submucous myoma. Or we can have a recurrence of the fibroid, which can happen in up to 27% of the cases. because we have a scar in the uterus, we might be facing another complication during a subsequent pregnancy, which can be a rupture of a uterine scar. Here we have the demonstration of an abdominal myomectomy where we do an incision and we open the capsule. We enucleate the myoma. After enucleation of the myoma, we just close back the cavity and the uterine scar. One of the famous procedures for a myomectomy is the Boney's hood operation, where we enucleate the uterus and we will be left with a hood that will be covering this cavity afterwards. Here we have a demonstration of a laparoscopic myomectomy or a hysterectomic myomectomy, as we said earlier, to remove a submucous fibroid polyp or a submucous fibroid that is less than 5 centimeters. Obviously, the most radical approach will be a hysterectomy. The hysterectomy includes surgical removal of the uterus, including all the fibroids it possesses. The indications will be, obviously, like the contraindications of the myomectomy. So it's done for postmenopausal women with symptomatic or with large fibroids, or in premenopausal women who have completed their family, or whenever myomata are so large and multiple, making myomectomy a high-risk procedure. The advantages of a hysterectomy over myomectomy is the sure relief of the symptoms with no recurrence, and the less blood loss during surgery, and thus the lower post-operative morbidity. The disadvantages of a hysterectomy will obviously be a loss of further fertility and a cessation of menstruation after removal of the uterus. A hysterectomy can be either an abdominal approach, whether it's a total abdominal hysterectomy or a subtotal hysterectomy where we leave the cervix, or a vaginal approach, or a laparoscopic hysterectomy. Thank you.